This is part 3 of Breech presentation lecture. Now we are going to discuss transverse lie or shoulder presentation. By the end of this course, the student will be able to list the causes of shoulder presentation, state how to diagnose shoulder presentation, describe the complications and diagnosis of neglected shoulder, state the management of shoulder and neglected shoulder presentation, diagnose shoulder presentation in the antenatal clinic and obstetric ward. When the baby is transverse, the presenting part will be the shoulder. It complicates 1 in 3,000 deliveries. It is due to failure to complete the rotation in utero, which might be due to fetal, maternal, and/or uterine power disorders as shown in the slide. We have 4 main positions according to the relation between the fetal scapula, which is the denominator, and maternal sacrum. The scapulo-anterior position, L.S.A and R.S.A, are more common than scapulo-posterior, L.S.P and R.S.P, because in the former the concavity of fetal front fits into the convexity of maternal lumbar lordosis. Again, diagnosis is by clinical examination and ultrasound. By history, the abdomen is enlarged from side with low level of the fundus. By abdominal examination, the fundal level is less than the period of amenorrhea. The contour of the abdomen is transverse. The fundal level is less than date of amenorrhea. The fundal grip is empty. By the umbilical grip, the head is felt on one side and buttocks on the other side. The pelvic grips are empty. By auscultation, the fetal heart sounds are best heard on one side of umbilicus and better in the scapulo-anterior position. Ultrasound confirms the diagnosis. X-ray studies are not used anymore. It is essential to differentiate between the elbow and the knees, as well as between the hands and the feet, as shown in this slide. The direction of thumb denotes the direction of the head, and the direction of the dorsum denotes the direction of scapula. The RT and LT hands are differentiated by shaking hand with the doctor. No mechanism of labor in transverse lie. Rarely version, rectification, expulsion, or evolution might occur. We have 3 methods for management of transverse lie, which might be CS, external cephalic version, or internal podalic version. This diagram shows the internal podalic version. Neglected shoulder presentation is similar to the presentation of obstructed labor. The case is presented by the arm. The arm is edematous. The vulva is edematous. The vagina is dry and ballooned. Liquor is completely drained. In neglected shoulder as well, the low uterine segment is very thin and stretched. The upper uterine segment is tonically contracted and short. There is high, pathological retraction ring. The fetus is dead or dying. The mother shows signs of maternal distress as tachycardia, pulse more than 110/minute, fever more than 38 degrees Celsius, and dry tongue, together with severe exhaustion. This diagram shows neglected shoulder presentation. The best treatment for neglected shoulder is caesarean section. In caesarean section, guard against extension by high incision in LU or US. Postpartum hemorrhage. Postpartum infection. In the next slides we are going to discuss a rare emergency, which is cord prolapse. By the end of this course, the student will be able to define cord presentation and prolapse, list the causes of cord presentation and prolapse, describe the complications that may be associated with cord presentation and prolapse, state how to diagnose cord presentation and prolapse. Describe the different ways of managing cord presentation and prolapse. We have 2 types of cord prolapse: occult and overt. Occult is defined as descent of the umbilical cord into the lower uterine segment and lies beside the presenting part and not easily palpated, after rupture of membranes. It can be diagnosed by fetal distress and Doppler. In overt cord prolapse, descent of the umbilical cord occurs into the lower uterine segment and lies below the presenting part and is easily palpated, after rupture of membranes. Cord presentation is a cord prolapse without rupture of membranes. The main etiology of cord prolapse is non-fitting of the fetal head on the cervix. Its incidence is 1 in 200 to 1 in 300. It is associated with prematurity, 34 weeks. 2. Abnormal presentation, breech is the commonest, 40 to 50%. 3. Cephalopelvic disproportion. 4. Pelvic tumors. 5. Hydramnios. 6. Multiple pregnancy. 7. Rupture of membranes. 8. Long cord. This diagram shows cord prolapse, cord presentation, and occult cord presentation. Management of cord prolapse depends on the gestational age i.e. the age of fetal viability, and the second important factor in determining the management is the fetal pulsations and at last the extent of cervical dilatation. If the fetus is dead, the labor may be left to proceed normally, if no other complication indicating caesarean section. If the fetus is still alive, emergency caesarean section must be carried out as soon as possible unless vaginal delivery by forceps or breech extraction is likely to be easy and straightforward. Prior to delivery we can place the mother in various positions to decrease the degree of cord compression, and this will be discussed in the face-to-face session. This diagram shows various maternal positions to decrease cord compression. If delivery cannot be carried out at once, an attempt should be made to replace the cord in the uterus. The prolapsed loop is wrapped round with thick sterile, warm gauze and pushed through the cervix to prevent vasospasm which result from cold and local irritation. We have to follow the rules in emergency CS so as not to jeopardize the maternal condition. Patient should be placed in the knee-chest position, genipectoral position or Sims position. Upward pressure against the presenting part to maintain the fetus away from the prolapsed cord and repositioning of the cord. Oxygen to the mother. Cord presentation is cord prolapse but without ROMs, and so more time is available. This diagram shows prolapsed cord into the vagina after membrane rupture with a high head. For prevention of iatrogenic cord prolapse, artificial rupture of membranes should be done at low head stations and fetal heart sounds should be auscultated after. Cord prolapse is a fetal hazard with no maternal effect. It can lead to fetal hypoxia and brain damage and can end in fetal death. Risk to the mother is mainly due the risk of emergency caesarean section. These are the pre-readings for the lecture. Thank you.